introduce you. You ready?
Yeah.
You ready, hot stuff? All right. Hey, see, you're mic'd up, okay. I gotta grab my iPad real quick. Hey guys, you ready to get started? All right, our next speaker is Dr. Victor Chin from SportsMed, Huntsville, Alabama. Dr. Chin, a fellowship trained anesthesiologist, Dr. Victor Chin, specializes in diagnosis and treatment of painful spine conditions in the Huntsville, Alabama office of SportsMed. Dr. Chin uses the latest in conservative and interventional pain management techniques to relieve pain. A native of Auburn, Alabama, Dr. Chin received an undergraduate from University of Alabama in Birmingham. He earned his medical degree from Johns Hopkins University in Baltimore, Maryland, and stayed in Baltimore to complete an internship in internal medicine at Mercy Medical Center at the University of Maryland. Dr. Chin then completed his anesthesiology residence at Harvard University, Massachusetts General Hospital in Boston, Massachusetts. During his residency, he received the Donald P. Todd Award for Excellence in Pain Management and went on to complete his fellowship training in pain medicine at Massachusetts General Hospital. In addition to managing painful spine disorders, Dr. Chin offers comprehensive care for other acute and chronic pain conditions. He has a passion for helping patients find long-term solutions for pain relief to reduce their dependency on opioid medication. He is also actively involved in workers' compensation cases and currently serves as a medical director for Peridigm Outcomes, helping injured workers across the United States manage chronic pain. Dr. Chin is certified in both anesthesiology and pain medicine by the American Board of Anesthesiology. He enjoys working closely with each patient and customizing pain management plans based on their unique needs and condition. Welcome, Dr. Chin.
Thank you so much for having me today. Can everyone hear me in the back? Okay, so my job was to talk about the choices you have in pain management and to relate it to the state fair. So I thought about food at the state fair because when you go to the state fair Midway, there's so many food choices. Unfortunately, none of them are good for you. And just like none of the food choices are good for you, when I talk to insurers, everyone hates pain management because pain management is the last thing you want to see. You know, if you're a doctor at a work comp conference and you say, hey, I'm an orthopedic surgeon. You're like, great, doc, nice to meet you. You fix the fractures, get the person back to work. Or you're an occupational health doctor. The insurers and adjusters say, great. You treat the back strain and get them back to work. And I say, hey, I'm a pain doctor. They're like, oh, you're one of those people that treats the claimants that never get better. And I'm like, well, it's not the way it's supposed to be, but sometimes, unfortunately, that's how it is. So needless to say, we know we're hated by every insurer out there, but it's an important job because some people don't get better and we have to do what we can to help things. Should I lower this a little bit? Is that better? Okay. All right. So let's get right along here. So I've kind of studied and been all over the United States. So I've seen a lot of different things. I got to treat some work comp patients in other parts of the country, and things can vary a lot between states and jurisdictions. It's really interesting what people focus on what parts of the country. So unfortunately, pain management, we call it management because we have very few cures, if any, right? So the joke I like to say is that in anesthesia, we don't really fix problems. We just help you get through something. In the operating room, when you knock people out, they say, hey, doc, just help me get through this surgery. And in pain management, people are looking to help them get through life, right, after an injury. And these are the people that get hurt and don't get better. And, the other joke is that if you have a lot of tools in your toolbox that you're using, they're probably all partially ineffective, right? Because if you had one treatment that was smash bam, you would do that. Like for gallbladder, most of the time, if your gallbladder gets really inflamed, what do? You cut it out, right? But what if like there were 10 different treatments, all of which you could try? Well, then you'd be like, maybe these are all partially not that helpful. Unfortunately, the state of the art in pain management is that we don't have a lot of silver bullets. So we're putting together a lot of things from our toolbox to try to help the patient get better, get back to work, get some kind of functionality so they can live the rest of their life. All right, so every time I talk to an adjuster or a case manager, this is what they're worried about. I call it the pain management gut buster. So when these cases get sent to me, man, it's just more on more. You got your base layer of narcotics. It's like the Frito chips, all right? Then you pour on the greasy chili, that's the muscle relaxant, and then some jalapeno peppers, the gabapentin, and then, oh no, the patient can't sleep, so you got to add on some salsa, and then a topical compounded cream because the doc's got to make some money on the side, right? And then meanwhile, they're taking these 5 things and you're wondering how they're breathing, how they're walking, and so on and so forth. And then the pain doctor calls you up and says, hey, I need to do some injections. And you're like, I just paid for these. Why do they keep going on? The patient's still taking 5 different meds. Then they want to add a scoop of like a narcotic pump in their spine or a spinal cord stimulator. So they just keep piling it up, piling it up, piling it up. And, objectively, it's very hard to prove that the patient is actually getting better. Some of them may or may not be going back to work, especially if they're taking all those medications. And it's just, it's really depressing. So that's the case that everyone points to as why pain management is really crappy. And, the vast majority of people get better, go back to work, but there are some people that unfortunately end up down this road where treatment after treatment keeps getting piled on. No one's clear what's doing anything, and everyone gets a horrible stomach ache and feels horrible the next day. So that's what I try to avoid, at least. I try to deconstruct this pie, figure out what things are doing what, get rid of all the stuff that's not working. And for me, less is more, because more stuff means more complications, means more interactions between medications, means more likely the patient can get hurt. Okay. So unfortunately, I've seen a lot of people get hurt by this traditional kind of pain management gut buster dish that people like sometimes. So pain, we actually use the International Association for the Study of Pain. They just updated their definition of pain. And I'd like to highlight here that it's both sensory and emotional. And the way they define it, this is kind of complex language here, but you can have actual tissue damage or potential tissue damage. So you don't even have to have, quote unquote, real tissue damage, but you can just have this sensation and not have true potential, true tissue damage and still be having pain as defined. And the important thing is that pain is always a personal experience. I added the word subjective here, that's influenced by biological, psychological, and social factors. Why is this so important? Well, this is what leads to the frustration. You'll have 2 different patients have the exact same injury, the exact same surgery. They may even have the exact same MRI with a mild disc bulge. One goes back to work and one is completely decompensated and has no function and has a miserable life that they report because of other factors. And a lot of it has to do with, do they like their workplace? Do they like who they work with? Is their supervisor mean to them? Things that you can't control, right? But the important reason to focus on the subjective and emotional component is if you just try to do what I call the electric wire analogy, find the part in the car and fix it, then you're going to be missing out on helping people. And that's why we think a lot of people don't get better, because we're not addressing the other component. We keep looking for, quote unquote, the painful broken part. and surgeon after surgeon tries to cut out something or rewire something or put something back together, and the patient's constantly looking for your cure. And some of them are very vulnerable to, a physician that may be unscrupulous and saying, I am the hand of God, I can cure you, I know what's good for you. And then they volunteer for another surgery that may be ill-advised, and then they don't get better. Not to say that surgery doesn't work. I mean, obviously you see that some people get surgery and get great relief and go back and have no problems, but that's what happens. You always got to pay attention, or at least I do, to that background emotional thing. What else is going on in their life? How are other ways that I can address their pain? Because focusing on that broken wire or broken part component may get you nowhere. So this is a complicated diagram here, just showing the brain. And the whole point of this thing is that there's signals that come in through the nerves, like your spinal nerve or any nerve in your body. It goes up to your brain and you sense pain, okay? Then the downstream component, your pain has certain mechanisms, your brain has certain mechanisms to affect your pain sensation. So your brain can send signals to actually block some of your sensation of pain. So why do I show this complex diagram? Because there are different medications and different ways that we can hit upstream and downstream things, okay? So this is kind of a list of different types of medicines. One on here is pretty controversial, cannabinoids, i.e. pot, okay? Capsaicin is chili pepper. We'll talk about some of these other ones here. The one that everyone hates, opioids. Ketamine is a drug that we use in anesthesia in the operating room all the time, but it's kind of become a latest, I call it like a hipster fad in medicine for outpatient treatment. Recently, ketamine was approved for nasal use. It has a nasal squirt bottle that you administer for severe acute depression under the supervision of a psychiatrist. But a lot of people are trying to explore ketamine taken as an outpatient to treat their pain. Ketamine is also a drug of abuse. A lot of veterinarians use it, and people love it at raves and stuff because you kind of get this psychedelic experience. In anesthesia, we call it a dissociative anesthetic. You're kind of there, but you're like floating beyond yourself or checked out. So you stay awake, you don't stop breathing, you slobber on yourself, and I'm serious, and you kind of like get spaced out. It would have been an ideal anesthetic in the operating room because it doesn't tank your blood pressure, it doesn't make you stop breathing, it gives you pain relief. The problem is it can have some psychiatric side effects. After it wears off, some patients still have hallucinations, weird dreams, and other stuff. So that's why we don't use it as often as we would like to, because otherwise it would be the perfect anesthetic. And these are a whole bunch of other meds, most of which you've heard before, but we'll get into that. But notice some medicines like ketamine and cannabinoids work on the upstream and downstream component. So they may be useful. All right, the tools in our toolbox. Remember, if you got a lot of tools to fix the same problem, they're all partially helpful or all partially ineffective. So number one, first thing I ask everyone when they come in, have you done physical therapy? Okay, I'm trying to move someone from here to here, right? Look at that guy. I mean, he's all positive and looking, smiling and everything. Most of the patients, by the time that they get to me, have had physical therapy, but it's surprising. Some people have not had physical therapy. And then I always ask, how much have you had? If you had one visit and then you quit because it hurt too much, I always tell them, please try to do the entire course, because going to the gym, you don't look like Popeye after lifting weights for one day. I mean, and any high school athlete will tell you that when you're working out for the football team or for the baseball team or something, you usually feel worse a lot of times before you start getting better. So I tell my patients that I want you to go to the several week course, the 10 or 12 visits, because it may take some time to turn the corner. So I always check, how many visits have you had? Did you participate? what were the reasons that you didn't go? But if they say I've been to 10 to 12 visits, these are the exercises I did, they helped, didn't help, are you still doing them at home? Then I get an idea of whether they had what I call an adequate trial of physical therapy or not. So that's the first important step before doing anything else, because that's the least risky thing. The frustrating thing for the patient is that it takes time. It's not a magic cure, right? And some people have trouble with their work. They may have trouble getting off work to go to their physical therapy appointments or so on and so forth. So sometimes that becomes a problem. All right. The first question I go into is the medications. What are the things that you try? I know at a pain clinic, everybody comes in with thinking OxyContin is rolling around up there. Some patients just cut straight to that, but I always go through all the non-narcotic stuff because opioids are the last thing you ever want to use because they're very dangerous. So we ask them about stuff. And, the general attitude that a lot of folks have is that these are only over-the-counter medicines. So the most common ones that we all know about are ibuprofen or Aleve or aspirin. Okay, these are just several different classes of anti-inflammatory drugs. So, people say, oh, well, don't give me a prescription ibuprofen or a prescription naproxen. That's not going to do anything. But sometimes you try a different type of drug, like one of my favorites is celecoxib, because it tends to have less stomach issues than some of the other ones, or meloxicam Mobic. I like that one too. Sometimes they actually make a difference. By the time you've tried 2 or 3 or 3 or 4, pretty much, however, you can kind of move on. But the things that we worry about with this is that they're not appropriate for everyone. So if I've got an injured worker that comes in and has diabetes that's pretty bad with like end-stage kidney disease, well, these non-steroidal anti-inflammatories could knock them out, could send their kidneys into failure and put them into dialysis. So obviously we don't want to do that. I always take a thorough history and physical for the patient. Nowadays, more and more workers have a gastric bypass, okay, to lose weight. That's generally a contraindication or something that you really need to avoid taking chronic high-dose anti-inflammatories for. Anybody with a stomach bypass is much higher likelihood of having a recurrent stomach ulcer or stomach bleeding from that. I actually had an injured worker who was 25, normal, healthy, young guy, hurt his back, had chronic pain. Some work comp doctor had been giving him high-dose anti-inflammatories for 3 years before he came and saw me. He developed an acute stomach bleed and had a stomach perforation from it. And so the general surgeon had to go in an emergency and cut out that bleeding ulcer. And then he had to get more treatment under work comp because it was deemed that the ulcer was caused by the prescription prescribed for his work-related injury. So you always have to be careful and mindful of, is this sustainable? Yeah, I can give you this for a couple of weeks, but if you've taken this for several weeks or several months, is it going to cause problems? And are you going to end up with another injury? So neuropathic medications. So by the way, I have some interesting cuts of state fair foods. So growing up in Alabama, I've been to my fair share of state fairs. And one of the things is the weird foods like fried butter, fried Oreos, right? So I thought that Alabama was the king of weird stuff, but I looked it up and like a lot of states have some really bizarre things. This one's not so weird. This is pickle pizza from Indiana. It's like straight up pickles on, this one has tomatoes on it, but some of the other ones I saw didn't. My next favorite class of medicines is what we call the neuropathic medicines, or medicines that we use to treat nerve pain, okay, or pain in general. The first class is tricyclic antidepressants. Nortriptyline is the one I commonly use. The other one is amitriptyline, okay? Other drugs, one is my favorite, duloxetine, Cymbalta. This is a different class of antidepressant there. I like these 2 drugs because they can do a lot for you, okay? So if the patient says that I'm having trouble sleeping at night, doc, because my pain hurts, nortriptyline is a good choice. You can take it at night, all right? It has a strong sedative side effect in some patients, All right, if they're feeling depressed down from their work injury, this also is an antidepressant. And it also works for nerve damage pain. We use it to treat migraine headaches all the time. It treats a lot of different pain syndromes. So you might get like a threefer with it. You might get pain relief, sleep relief, and mood help with it. And the side effect profile is pretty low compared to other things. Duloxetine is my next favorite one. It's now generic. It's been generic for a couple of years, which I was really happy with because it used to be very expensive, but now it's pretty affordable. This one, you've probably seen the commercials for. We use it to treat fibromyalgia pain, right? It has the FDA indication for chronic musculoskeletal pain, and it also has an indication for diabetic nerve damage pain. All right, granted, we're not treating folks for fibromyalgia or diabetic nerve damage in work comp, but we use it off-label to treat a lot of the same nerve pain syndromes like sciatica, like pain running down your leg. Now, you can always use it for chronic musculoskeletal pain. So if I have a patient that has, say, a bum knee after a work injury and the surgeon has done all they can or deems them not to be a surgical candidate, and they fail non-steroidal anti-inflammatories like ibuprofen or Aleve, I'll switch to duloxetine. Why? Because it has an FDA indication for chronic musculoskeletal pain. A lot of the national guidelines suggest using it. It's a lot safer than an opioid. It's generic, and the side effect profile is low, and it's not thought to be addictive. So that's why I use those medications. A lot of the adjusters or case managers may not be aware that these have dual indications. And everybody is really afraid of a psychiatric diagnosis because, you know, no insurer wants to expand the scope of coverage. So anytime you write one of these medicines, I take care to put down, I'm using this for neuropathic pain, not for the depression, you know, or I'm saying, yeah, I'm using it for the depressed mood, but my primary purpose is to treat their musculoskeletal pain. So I try to put that clear in my notes so folks understand that I'm not, you know, what do you call it, wandering off the path. And I explain that to the patient. I'm like, look, you know, we're only allowed to treat your work-related injury, but these are some of the extra benefits you might get from your medication. So that's important to note there. Muscle relaxants. This is a class that I try to stay away from. No one knows exactly how these work. When I was in medical school, I thought, oh man, that's cool. It goes to the muscle and like makes it like stop spasming, right? Thought it was real specific, but basically no one knows exactly how they work. There's a certain part of your brain that they seem to act on. It just makes you go like that. So the main side effects of muscle relaxants are sedation, sleepiness. Some people don't have those, and some people find them quite helpful. These muscle relaxants are the ones that tend to be less addictive. One that we don't use, well, I don't use at all, is something called Soma, okay, carisoprodol. That one has very benzodiazepine-like properties like Valium, Klonopin, Xanax. Folks used to use it all the time as kind of an old school pain drug, but it's been associated with a lot of increased deaths. Okay, so the DEA put it on their target list, and they basically started looking for doctors that write the magic trio. We used to call it the magic trio. So some kind of opioid, Soma, and then a sleeping pill or something like that. And they would target doctors that wrote that combination and go and investigate them. So nowadays, fewer pain doctors write it because they don't want to get investigated, but you'll still see it out there. So if someone's on it, I always try to taper them off and switch to one of those more safer ones. And this is a picture of a hot beef sundae. So I was like, what the heck is that? So the bottom is like mashed potatoes and some kind of chili looking thing, sour cream, tomato. I guess that's guacamole. I'm not even sure what that is. But apparently this is a big thing in some of the Yankee states. So I was like, go figure. Oh, yeah, that kind of looks cool. But I mean, I'm not knocking it. I've never tried it. So I just thought it just looked really interesting. Tizanidine is the one. These two I like Flexeril tends to be more sedating, and this one can interact with some antidepressants. So if I'm writing someone duloxetine or amitriptyline, I try to stay away from this one. If the patient is taking an antidepressant for a non-work related mental health condition, I also try to stay away from this one, mainly because they can interact. But those are the ones I generally use if I decide to use one, but it's not my first thing because they tend to be sedating. All right, topical agents. These are a little controversial because the evidence behind them is pretty weak. The reason why we throw them at everyone, or some people throw them at everyone, is because they're very unlikely to have any side effects, right? The main side effect is rash, but it's pretty hard to get addicted to any of these things. So capsaicin is chili pepper cream. All right, so for some nerve conditions, especially shingles, like shingles pain, people will rub it on there and it makes it worse initially, but the way it's thought to work is that it keeps flogging your nerves to release all the pain juice, and then it basically fatigues your nerves out. So just kind of whips them, and initially you get worse pain, and then it kind of tires out the nerves so that it can't fire anymore. That's how it's thought to work. The lidocaine patches make things numb, okay? And diclofenac cream, that's a Voltaren gel. Voltaren arthritis available over the counter now, but you also have prescription formulations. I like it because, and for some people, say if you got chronic joint pain after a work injury, this is a good choice because it's safer than taking it orally. You get a lot less systemic absorption. So the literature suggests that you'll be less likely to get a stomach ulcer or something like that. And so if this might be a good choice for someone with joint pain after it. This is an ice cream potato from Idaho. And at first I was like, that looks like a potato, but it's really ice cream. And then they like put cocoa powder all over it to make it look like a potato, and they cut it down the center. And then this stuff that looks like sour cream is like, whipped cream and some kind of nuts or other things. And I even saw one where they had like ice cream shaved to look like cheddar cheese. They had little sprinkles on top. So that's kind of cool. I don't know if I could eat that whole thing because that looks pretty big, but maybe get it for the family or something like that. All right, this is the class that everybody hates, and rightfully so. This is the one that we get, the pain doctors have the deserved epithet of being the legal drug dealer. We turn to these when nothing else works. And a lot of patients say these help them. Unfortunately, when you look at the evidence, there's no good evidence that these are safe or effective beyond 6 months or a year. And a lot of the doses folks get in the community have no good evidence behind them. So it's really controversial, but we use them because they seem to help certain people. And if you've tried everything else and nothing works, some people do report better function and pain and able to return to work when taking these things, especially if they don't have the side effects. I tend to, if I have to use these things, I tend to stick with the immediate release formulations. A lot of people used to advocate for the long-acting stuff because it lasts longer. The long-acting things are more expensive. There seems to be a higher risk sometimes of oversedation or accidental overdose with the long-acting ones. So I generally tend to stick to the generic short-acting ones because the evidence suggests they may be safer, they're cheaper. And then I tell the patient, if you don't need it, don't take it, right? Whereas the other one, you're kind of soaking your body with a narcotic all the time. And then there's some theoretical risk that may lead to increased tolerance, or where the medicine doesn't work as well as it used to. So that's the thing. Tramadol, when it first came out, people will say, oh, that's a non-narcotic. It really is an opioid. It binds to the same receptor that these other things do. It's just not as potent. So they scheduled it as a class 3 narcotic, and that actually quickly became one of the most commonly abused drugs amongst healthcare professionals because it was a lot easier to get, and people were like, oh, it's non-narcotic, it's not that bad, but it really is. If you look on the DEA website, they have a big paper talking about how this is a drug of abuse, it is an opioid, so on and so forth. You can get addicted to it. Patients will often ask which one of these is better. there's really not one that's necessarily better or more dangerous. It's all about the potency and the dose. So yeah, is oxycodone quote unquote stronger than hydrocodone? It's just more potent. So 5 milligrams of oxycodone is worth about 7.5 milligrams of hydrocodone. Okay, does that mean it's better? Well, not necessarily. It's how you dose it. So if you get the same doses, these all can kill you. They all can cause constipation. They all can make you crazy, can mess with your hormones. For the young guys, I always tell them that can suppress their testosterone levels. And sometimes that's a real put off. So they want to stay away from them. Because it's true. I mean, I've had people transferred to my clinic where they've been pounded with OxyContin and they're 25 years old, right? And then their testosterone level's low and they wonder why. And then they're giving them like Viagra on top of it and testosterone shots to kind of cover up the mess that you made before. And I think it's really sad, but I mean, that does happen. The other things are increased mental health problems, weakening of your bones. You're more likely to get infections when you take these things at high doses because they suppress your immune system. And so we always review the risks. That's why I take a clear mental health history with anybody who gets hurt. Do you have a pre-existing history of depression or anxiety disorder? Have you ever been hospitalized? Have you ever tried to kill yourself? Because pain gets you down. I've had injured workers where they come to me from someone else or somewhere else. They've been injured for 2 or 3 years. They're just barely making it along, and then they can't take it anymore, and they, get suicidal, and then we have to get them help. So you want to know that before you put somebody on a med that can potentially really tip them over the edge, so that how to get them help and what you need to do for them. Okay, this is a deep fried cereal from California. This one is looks like Cinnamon Toast Crunch, but they had the tricks too. They like put it in this batter and like deep fry the whole thing, and then it looks like a beignet or something. But the other one with tricks looks a little weird. I even saw deep fried jelly beans where they kind of ooze out, like when you bite into it. And like all the internet forums say this stuff is awesome, but I don't know. To me, it looks like pretty icky, but whatever. All right. The next thing that you probably hear the most about are injections or devices. This is like something I definitely don't go to first. The reason why is because these are more risky, right? I mean, the risk of getting paralyzed from a needle is extremely rare, or getting an infection or getting worse pain from injection is very rare. But, if you try physical therapy and that works, you don't need an injection. If you can take a non-narcotic medicine, get better, and then taper off that medicine, you don't necessarily need an injection. Why do you hear so much about these? Why are there a lot of docs pushing these? It's because we have a strong financial incentive to do these. So I'm not saying that these are never indicated, because with the exception of the opioid pumps, which I don't believe in, I do all the other procedures when indicated. The reason why you'll hear people push these and say, oh, let's not give them addictive opioids, let's just do the epidurals and stuff. I mean, that's fine if they tried all the other non-narcotic stuff. These generate a lot more revenue, and many physicians, let's just be honest. I mean, I don't want to trash my own people, but like, there are a lot of folks that just out there to drill and bill, operate, make the money, do the injection, and then they send them to me and they're like, oh, I've done the 10 epidurals, but they still have pain. I'm not a pain doctor. Well, you've been writing narcotics like a pain doctor. Oh, I'm not a pain doctor. I don't know if they can go back to work. I'm going to transfer them to Dr. Chin and he'll tell them whether they can go back to work or not. And like, if they had the injections and they don't work, then I'm not going to do them again. All right. But I mean, that's why people focus on that, because it generates revenue, and it's a lot easier to stick a needle in someone's back or do something rather than actually talk to the patient, try to find out what helps, what doesn't. Okay. The most difficult conversation I have is when I'm telling the patient, look, you're at maximum medical improvement, you still hurt. These injections didn't help. There's not a reason to do them. You're not a candidate for surgery. We need to assign you a permanent impairment rating and a work status. And a lot of people just don't like that. They don't want to, some people say they can't go back to work and they get really angry, right? Or they want the OxyContin at the super high doses that you know is dangerous for them, and you don't want to give that to them because it's going to kill them, right? And so that becomes a very difficult conversation. So it's really easy for the surgeons or people that just do the injection to just say, hey, you know, the injection didn't work, it's not my problem. The surgery didn't work, not my problem. You know, I made my money, go see Dr. Chin, right? Then I'm the one that gets yelled at and people tell me to go back to China and all this kind of stuff. No, I'm serious. I'm serious. I've had at least 2 work comp patients when I told them they needed to go back to work because of what we, you know, I said I would keep treating their pain, but I couldn't hold them out of work forever. And then when we're talking about holding them out of work completely, they didn't want to go back to work at all. So then they were like, well, you need to go back to China. And I'm like, okay, right. So, I mean, it's not okay to be racist, but what I'm getting at is that that's why no one wants to have the conversations that I have, because it's not easy, right? Do you want to sit there and get yelled at and people threatening you and threatening to sue you because you're not giving the OxyContin and yeah, now I need to go back to China? Nobody wants to do that, right? So everybody just wants to do the injections and then dump them off on me, all right? So that's what happens. Now, the spinal cord stimulator in a very selected population may be appropriate, but in workers' comp, there's been several studies showing that whatever treatments that work in the outside population for some reason don't work as well in some workers' comp patients. And a lot of will look at me and say, you got to be kidding me, a spinal cord stimulator? They're really skeptical of it. And they just think it's another gut buster add-on, right? You already piled on all the other stuff and now you're just going to slam something else on top. But if you're really picky about it, some people will get good pain relief from these and can come off other drugs. Me personally, if I'm ever considering putting this in someone during the trial, I make them taper off like the opioid medication during the trial, because I want to know, is this working such that you don't need the narcotic? Or is the narcotic better? If you have a legit indication for an opioid and you tried all the other safer stuff and you got like a 5-level fusion in your back after falling at work or getting crushed by the bulldozer or something, then you can stay on the opioid if you tried everything else. But what I don't want to get into is a situation where you're on the stimulator, you're still taking the same pills, if not more, right? I don't believe in intrathecal opioid pumps, the so-called spinal opioid pumps, because those are designed to deliver extremely high doses of opioids. In general, I don't believe in high doses of opioids for non-cancer pain or non-terminal pain, because I think the risks outweigh the benefits. If you're dying of prostate cancer or you have metastatic lung cancer and you have metastases all over your bones, that might be an appropriate option. Where I trained at, we only use them for end-stage cancer patients, and there they can make a difference. But for the guy that got hurt at work that has a 3-level fusion, where you're trying to preserve some kind of function in life, right? I don't like the opioid pumps. And then the even craziness on top of that, I've had several patients where their opioid pump, I will review the file, and then they're also taking oral narcotics on top of the intrathecal narcotics. And I tell the patient, I'm like, you know, the ratio of the amount of medicine you're getting through your spine is like 1,000, and the amount you're getting through the pills is like 10. So it's like pissing in the wind compared to what you're getting in your back. And to me, it makes no rational sense. But some people really like that medication, you know, taking that pill. But I've never been a fan of the intrathecal opioid pumps, and some of them can be really dangerous because if they back up or if they leak or they run out, somebody can get hurt and they end up in the ER and have problems. So deep fried scorpions at the Arizona State Fair. That looks a little iffy, but I think I'd try it. I think I'd try it. All right. Well, that's all I have. I used to care, but you know, I take a pill for that now, so I'm better. Anybody got any quick questions at all? Yes. Yeah. Yeah. Some people, can get benefit from some of the compound creams. The controversy is that they're extremely expensive. A couple years ago when Medicare was still paying for them, like every pharmacist on the street corner would come with their own compounding clinic. And then I was reading they're getting like $2,000, $3,000 a month. Some of the medicines actually have no evidence behind topical use. Like they'll put in like, oh, let's sprinkle in a little gabapentin for neuropathic pain. I'm less of a fan of those. If it were straight up like Voltaren gel or the lidocaine ointment, I'm okay with that. I'm less enthused about those compounded things. As a reviewer, when I review those charts, I look to see what else they're on. If they're just on the topical cream, which is extremely rare, and it's a neuropathic condition, like say they had a crush injury to their leg, I'm less likely to, raise a fuss about it. But if it's the gut buster treatment where they're on, narcotics, anti-inflammatory, sleep pill, pain pill, testosterone supplements, and the compounded cream, then I'm like, this doesn't make any sense. Yes. I take referrals from outside. Well, a lot of times people just put us on panels and they don't tell us. So, it's not like I have a choice. You know what I mean? I didn't know I had a choice. People just like, yes. Yeah. Yeah, again, is it the gut buster treatment or what have you? If they were only getting the stimulator for the neck and the back pain, I could see that, but typically it's with a whole bunch of other stuff. And then, what are the results of the trial? And it's hard to say. It's all the devil's in the details, so to speak. But I'm telling you, everybody in the community for non-work comp will put that in every day. Not me, but a lot of people do. So, yes. No. Yeah, no, that's fine. Yeah, no, same questions, exact same answers. But what I'm telling you is that, sometimes people will like basically send cases all elsewhere. Everybody else will do the injections, they'll do the surgery, they'll write them ridiculous meds, and then they'll dump them. And so like I get annoyed when that happens because it's like I'm an honest dude, right? I'm not going to repeat all the injections and do all this stuff that wasn't necessary. But sometimes I can't take cases where they just and it's like that. It's the insurer's choice, but it's bad for the patient because they're not getting what they need in the long term. But if you're wondering why everyone does that, it's mainly because of a financial reason, because it's easier to just do the injection again and then not be told you need to go back to China and then get things taken care of, right? So you got to read my Yelp reviews. They're horrible. It's like he made me go back to work even though I'm hurting. I told him he needed to go back to China. I'm like, great. Yeah. All right, thank you so much. Oh, one more question. Yeah, sorry. Oh, good question. What if they have a boo-boo on their urine test? Depends on what it is. Okay, so say if it's alcohol, I tell you, you got to stop any alcohol if you want to keep taking the narcotics. If it's some medication that's not prescribed to you, depends what it is. Okay, so let's say it's a benzo or something, I might give you a warning because I look at the prescription drug monitoring program so I can see what you're getting. If it's some opioid you're not prescribed, I may give you a warning. I may taper you off. It depends. If it's anything illegal like cocaine, definitely, or methamphetamine, taper off. Okay. The new guidelines are more suggested that we taper people off a lot slower. We used to taper people off in a month, but some patients get suicidal and have problems with that. So now they're encouraging a very slow taper. So if you see any patients that I've had a bad test, it might take me 3 or 4 months to taper them, whereas in the past we do it in a month. So it depends on a case by case basis. But yeah, obviously, if they keep taking bad stuff over and over again, then I gotta taper them off. And then I tell them I can still be your doctor. I just can't give you opioids, right? Yes. Yeah, if they're on methadone, it depends what the indication for. If they're using that for substance abuse disorder, I generally would avoid giving them chronic opioids. I'm not an addictionologist. I don't have that licensure, so I stay far away from that stuff. But if someone has an addiction to that stuff, then I'll refer them to the necessary clinic. But I don't like chronic methadone or Suboxone. Now, some people can use methadone for chronic pain. I don't like doing it because it can be pretty dangerous compared to other opioids of equal analgesia. Methadone is a little weird. It can cause some bad heart arrhythmias and some other stuff that can kill you. So I really don't like writing methadone at all for non-malignant pain and non-substance abuse folks. So, yes. Yes, I do non-opioid medications. Usually the ones that I talked about, tricyclic antidepressants, duloxetine. I don't have any Schedule IIs in my office. I don't want to get held up at gunpoint or anything like that. Yeah, that's another controversy because sometimes it costs the insurers more. The folks that I work with usually are negotiating with the insurer or the adjuster. So if they have a problem with the reporting or the cost, they usually call our pharmacy partner and then they negotiate something so that it's reasonable for you guys. Yes. Yeah. Yeah. Yeah, what is the indication for Suboxone substance use disorder? Like he had an addiction, or is it just for pain, or what? Yeah, because like the addiction world is real controversial. Some addictionologists recommend staying on Suboxone lifelong because they have the analogy that your brain is permanently damaged. If you come off Suboxone, you're more likely to relapse and die. Other people say you need to make behavioral changes. We need to get you to the counseling. You need to stay away from your triggers, your bad friends, and the bad people that encourage you to do drugs. We're going to taper you off gradually. The critics say that, oh, methadone is changing one addiction for another, or Suboxone is changing one addiction for another. The addiction world is very split on that. So if he's taking it for substance abuse disorder, you might have to defer to the addictionologist. But the general rule of thumb is, like, say if someone's on Suboxone, right, and they have narcotic addiction and then they get surgery, the current national guidelines from the anesthesia societies are to continue the Suboxone, put on top of that short-acting narcotic to cover the acute surgical pain, and as soon as you can, taper them off the stuff and leave them back on the Suboxone. Right. The previous thinking is that we would taper them off Suboxone, do the surgery, give them short-term narcotics, and then put them back on the Suboxone. But lately, the evidence has shown that people that do that are more likely to relapse with addiction and have all other kind of problems. So now the current guideline is to keep the Suboxone the same throughout surgery, short-term narcotic. I just had a patient that had that problem, non-workers' comp, but taking Suboxone for that, and that was their plan because she was getting spine surgery. She was like partially paralyzed and needed some urgent spine surgery. So, all right.
Doctor, thank you,
Thanks.
Dr. Chin. I've been asked to announce that if you're an adjuster and you need credits, there is a box at the back of the room with